Hello to all dear students. So in continuation with our chapter, that is design of dosage regimen, we are about to start our second topic, which is conversion from intravenous to oral dosing. So the ideal route of administration for any medication is one that achieves serum concentration sufficient to produce the desired effect without producing any undesirable effects. So this is so true. For a therapeutic action to be produced, the drug should attain an appropriate plasma concentration, not more than that and not less than that. If the plasma concentration is more than required, then it is likely to produce an adverse reaction, and if the plasma concentration is lesser than expectation, then it will not produce any kind of action. Okay, so the medications should be such that an appropriate serum concentration should be achieved. So in the past, patients were switched to oral therapy to continue treatment after an already adequate course of intravenous therapy was being administered. But today, it is not uncommon to convert a patient to oral therapy as part of the initial treatment of course. So the available oral formulation on the market are easier to administer, safe, and achieve desired therapeutic concentration, thus making the oral route an ideal route of choice. And obviously, even you people, you all will prefer oral medication when compared to the intravenous route of drug administration. Means everyone. There are so many pros and cons for both the routes of drug administration. But in all, everyone will prefer oral therapy in comparison to intravenous route of drug administration. So the reason is the patients are more comfortable if they do not have an intravenous catheter in place. So attachment to an intravenous pole can restrict movement, which can hinder early and or frequent ambulation. Moreover, patients who continue to receive a parenteral therapy are at increased risk of infusion related adverse events. In addition, the presence of an intravenous catheter may provide a portal for fungal and bacterial growth. So, for these secondary infection, it can lead to an additional antibiotic therapy also. Using a oral therapy also reduces the hidden cost, such as cost of intravenous sets and pumps, laboratory monitoring, and nursing and pharmacy personnel time. And most significantly, early use of oral therapy may allow for early discharge from the hospitals. Okay. So these are all pros and cons. You can say the advantages of oral therapy when compared to the intravenous therapy. Next, we'll check out few types of intravenous to oral therapy conversion. So there are three types of intravenous to per oral therapy conversion, and they are: first one sequential therapy, the second one is switch therapy, and third one is the step down therapy. So we'll check out all these one by one. So starting with the sequential therapy. So it refers to the act of replacing a parenteral version of the medication with its oral counterpart. A very simple example is conversion of famotidine 20 mg to famotidine 20 mg per oral. Okay, so same drug, no changes in the medication. Famotidine is only given, and even the dose is also same. Previously it was given 20 mg intravenously, and now famotidine is given orally, same 20 mg. So there is no changes over here in the sequential therapy. So there are many classes of medications that have oral dosage form that are therapeutically equivalent to the parenteral form of the same medication. Okay, so this is about the sequential therapy. Next, we'll check out the switch therapy. So it is used to describe a conversion from an intravenous medication to the oral equivalent that may be within the same class and have the level of potency but is a different compound. An example is conversion of intravenous pantoprazole to rapidly dissolving lansoprazole tablets or omeprazole capsule. Now we know these all drugs are used for the treatment of peptic ulcer. Okay, and peptic ulcer can be treated by not only these agents, but we have got histamine antagonist, ulcer protective, so many agents are there. But these drugs, pantoprazole, lansoprazole and omeprazole, these all are coming under the same class, that is the proton pump inhibitors. So previously when pantoprazole was given intravenously, it can be replaced by oral therapy of lansoprazole or omeprazole. Okay, so this is switch therapy. In switch therapy, what we are doing, we are changing the drug, but the drug should be of the same class. But previously in the first therapy, that is the sequential therapy, here nor the drug, neither the dose was being changed. But in the switch therapy, we are changing the drug, and drug may be of the same class. Okay, so this is switch therapy. The last third one is the step down therapy. So it refers to converting from an injectable medication to an oral agent in another class, or to a different medication without the same class, where the frequency, dose and the spectrum of activity in case of antibiotics may not be exactly same. A simple example is converting from ampicillin 3 gram intravenous 6 hour to amoxicillin 875 mg per oral every 12 hours is an example of step down therapy. I hope this example is sufficient for explaining this step down therapy. Okay, means here the drugs are selected of different class, that's it. Next we'll see selection of patients for intravenous to per oral therapy conversion. Okay, next means what kind of patients can be selected to switch from intravenous to oral therapy. So proper identification of patients, diagnosis, medications and contraindications to oral therapy are all essential aspects for a successful intravenous to oral therapy conversion program. It is very important that the pharmacist conduct a thorough and complete review of these areas, so only the most appropriate patients are converted. Doing so is a benefit to both patient care and professional credibility. The criteria used to determine whether or not the patient is eligible for the oral therapy vary from hospital to hospital, but they generally encompasses the following 4 key areas, and they are: first one, intact and functioning gastrointestinal tract. Obviously this is the most important because we are taking the drug orally, so your gastrointestinal tract should be working all right, because absorption occur mainly by gastrointestinal tract only. The second thing is improving clinical status, means the patient obviously is suffering from some kind of disability or some kind of disorders, and for which we are giving the drug via intravenous route, and the person is improving, and same kind of improvement should be happening with the oral therapy as well, that is the improving clinical status. Third one is does not meet any exclusive criteria. There are some exclusive criteria, like why we are using intravenous, means under what circumstances we are using intravenous routes of drug administration. Yes, when there is any emergency condition. So, and under emergency condition we cannot prefer the oral route of drug administration, means if any person is suffering from you can say shock, so in that case we are giving intravenous epinephrine or norepinephrine. We cannot prefer oral dosing, because that is a kind of emergency case and we want the drug to act very quickly. So a drug can act very quickly if its absorption is quick enough, and we know that any drug which is given via intravenous route, for that the absorption is 100% and it will be immediate as compared to drug when it is given via oral route. Okay, and lastly others, will check out what is those others. So starting with the intact and functioning gastrointestinal tract. So the ability of gastrointestinal tract to absorb the medication is critical for successful conversion to oral therapy. So factors that influences absorption includes gastrointestinal pH, surface area and permeability. Like suppose this is your gastrointestinal tract, and we know in the stomach area the pH is acidic in nature, and in the intestinal area the pH is alkaline in nature. And even the surface area is more in the intestine because of large number of villi and microvilli. Okay, and how this will affect the permeability of a drug? Yes, a drug for inducing absorption means for crossing this biological membrane of the gastrointestinal tract and to move into the systemic circulation, a drug should have got a property of lipophilicity, or you can also call it as it should be in unionized form. So any drug, which suppose a drug is acidic in nature, so it should be present in an acidic environment so that it remain unionized and therefore can easily cross this barrier and absorption takes place. Similarly, any drug which is alkaline in nature, it should be present in an alkaline environment like that of intestine so that it remains in unionized form and therefore easily absorption takes place. Okay. Next, blood flow to the gastrointestinal tract is also important. Yes, this is also very much important. Therefore, patients which are displaying signs and symptoms of shock, they are not good candidates for conversion to oral therapy because blood flow is typically shunted away from gastrointestinal tract secondary to the shock itself or due to concomitant vasopressor therapy. Next, in continuous, now we'll check out the criteria indicating absorption of oral medications may be compromised. Means there are certain situations which we cannot, means under these circumstances we cannot give any drug via oral route, and the number one is NPO status. NPO stands for nil per os, or nothing to be taken via the mouth. Okay, under such circumstances we cannot give the drug via the oral route. Next is NG tube. NG tube means nasogastric tube. Nasogastric tube means here the person obviously will be unconscious in nature. Therefore, we have got a tube that starts from nose and the second end will be in the gastrointestinal tract. Okay. So, NG tube with continuous suction. At this case, we cannot give drug via oral route. Next, severe and persistent nausea and vomiting. Obviously, we cannot even think of giving drug orally. Next, gastrointestinal tract transit time too short for absorption. Means there are certain cases like malabsorption syndrome, partial or total removal of the stomach, or short bowel syndrome where this kind of problem may occur. Next, active gastrointestinal bleeding. High doses of vasopressor medication. See, vasopressor, these are the agents which are mainly used for the patients who are suffering from diabetes insipidus. And when you are giving a very high dose of vasopressor, we should give it via the intravenous route. We cannot give it via oral route. Lastly, difficulty in swallowing or loss of consciousness and no NG access available. So this is also a condition where we cannot give a drug via the oral route. Next, documented ileus or gastrointestinal tract obstruction. So, we cannot give the drug via oral route. And lastly, continuous tube feeding that cannot be interrupted and patient requires a medication known to bind to the enteral nutrition formulas. So, these all are the criteria that indicating absorption of oral medication may be compromised. Means under these circumstances, we cannot give the drug via the oral route. Next, the following guidelines are provided to help manage the conversion from intravenous to oral therapy in the presence of continuous tube feeding, and they are: select the most appropriate oral formulation of the medication for NG tube administration. Firstly, next, solution or suspensions are preferred over tablets. Obviously, if this is not available, then a tablet is taken and it is crushed, provided these tablets should not be an extended release or enteric coated tablet. Okay. Next, dissolve the tablet in a small amount of liquid to make a slurry and then draw the preparation into an oral syringe for administration. Once the medication has been administered, all the equipments used in preparation and administration should be rinsed and those washings should also be administered. Obviously, we don't want any changes in the dosing. Feeding tubes should be flushed with water both before and after medication administration to avoid blockage. For medication considered to be compatible with tube feeding, stop the feeding and administer the medication as specified above. For oral fluoroquinolones, Stop the tube feeding for at least 2 hours before and 2 hours after the administration. For phenytoin, which is dosed more than once a day, tube feedings can be stopped approximately 1 hour before and 1 hour after medication administration. Medications should never be added directly into the tube feeding. So these all are the guidelines which are provided to help the management of the conversion of intravenous to oral therapy. Under what conditions? Under the presence of continuous tube feeding. Now this completes our first criteria. Now we will go to the second criteria, that is improving clinical status. So signs and symptoms of the condition for which the medication is prescribed should be improving or resolving in patients being converted to oral therapy. Obviously, the patient should be clinically stable and deterioration should not be expected. So the following observations normally made to assess the appropriate clinical status for conversion to intravenous to oral therapy are: patients with active infections who are receiving antibiotics should be afebrile or have had a maximum temperature of less than 104 degree Fahrenheit in the previous 24 hours. Next, WBC count should be trending downwards, indicates that the patient's inflammatory response associated with the infection is declining. Next, it is important to examine the patient's medication therapy for other medications that can cause an increase or sustained high WBC counts, such as steroids. In this case, if the patients meet all other criteria, a safe conversion to the oral therapy can still be made. Conversely, if patients who are neutropenic means it defined as absolute neutrophil count which is less than 500 cells per mm cube. So patients who are neutropenic, the neutrophil counts means they are typically excluded from the intravenous to the oral therapy conversion, but this can vary from institution to institution. It is also important to review the cultured pathogens like bacteria, fungi, etc. and ensure that it is susceptible to the oral medication. If no pathogens identified, the oral agents should cover commonly suspected pathogens based upon local sensitivity or infection type. When converting from intravenous to oral therapy, the selected oral medications should have activity against these organisms in the absence of a positive bacterial culture. If gastrointestinal bleeding is present, documentation that the bleeding has stopped should be verified before converting to oral therapy. For cardiovascular medications, the patients should have stable blood pressure and heart rate. For anticonvulsant medications, the patient should be stable and not be actively seizing. If in doubt, review the chart or discuss with the patient's nurse. Okay, so these all are the improving criteria. Now we are going to the third, that is exclusive criteria. So very first thing is regarding the antibiotics. Oral therapy can be commonly used to treat a variety of infections. However, there are certain infections that should be treated with parenteral therapy due to the severity or location of infections. These include endocarditis, meningitis, brain abscess, orbital cellulitis and other central nervous system infections, osteomyelitis and endophthalmitis. So for these conditions, we cannot prefer oral therapy. We are preferring intravenous therapy only. Next, patients with multiple antibiotic allergies may be restricted to therapy of choice that may only be available parenterally. Okay, so this is regarding the antibiotics. Next, anti-epileptic medications. Patients who are at risk for actively seizing or are unable to tolerate oral medication without risk of aspiration are not appropriate candidate for the oral therapy. Next, cardiovascular medications. Patients with unstable cardiac condition or for whom frequent dose changes are occurring, for example through intravenous drip titration, are not good candidates for the oral therapies. So under these circumstances we should restrict to the intravenous therapy only. We should not switch it to the oral therapy. Next, others. Some hospitals may require that patients have received at least one dose of intravenous medication or have been hospitalized for at least 24 hours. Changing the route of administration from intravenous to oral results in direct cost reduction like medication cost, supply cost. Next, personal time spent preparing and administering dose is greatly reduced. And lastly, proactive conversion to the oral formulation reduce the length of stay and save medication or supply cost and total hospital cost. Okay, so these all were the various criteria. Next, we should check out some of the pharmacokinetic consideration also. So the very first thing will be bioavailability, obviously. So bioavailability is the commonly referenced pharmacokinetic parameters. So obviously whenever we check the differences between the intravenous and oral route, the bioavailability has the major difference, because in case of intravenous route the bioavailability will be 100%, but in oral route bioavailability will never be 100%. Okay, so for oral medications bioavailability may be less due to variability in the rate and extent of dissolution of the oral form and the total amount that is absorbed into the systemic circulation. When intravenous infusion is stopped, the serum concentration decreases according to the first order kinetics. Therefore, if the patient starts the dosage regimen with the oral drug product at the same time as the intravenous infusion is stopped, then the exponential decline of serum levels from the intravenous infusion should be matched by the exponential increase in the serum drug levels from the oral drug products. Okay, so what we expect, whatever you do, whatever changes in the route of administration you do, but the plasma concentration of the drug should be constant. So the following two methods can be used to calculate an appropriate oral dosage regimen for a patient whose condition has been stabilized by an intravenous drug infusion. Both methods assume that the patient's plasma drug concentration is at steady state. Okay, so we have got basically two methods and we will check them one by one. So method 1, C infinity below AV. This means steady state, or you can say average steady state concentration. Okay, so average steady state concentration is equals to SF D naught divided by KVD tau. We can rewrite it in this manner. D naught divided by tau is equals to average steady state concentration into KVD divided by SF. So here S is equals to the salt form of the drug, D naught divided by tau is the dosing rate, and we know D naught is the initial dose, tau means time, K means elimination rate constant, and VD means the volume of distribution. So this is the first method by which we can calculate the dosing rate, or you can say the average steady state concentration of the drug in the plasma. Next we'll go to the method 2. So this method assumes that the rate of intravenous infusion mg per hour is the same desired rate of oral dosage. Okay. Now we'll check out one example and then we calculate it by using both the methods. So the examples goes like this. An adult male who is asthmatic patient, age 55, weight 78 kg, has been maintained on an intravenous infusion of aminophylline at a rate of 34 mg per hour. The steady state thiophylline drug concentration was 12 microgram per ml and the total body clearance was calculated as 3 liters per hour. Now calculate an appropriate oral dosage regimen of thiophylline for this patient. Okay, so few values are given and lastly what we need to calculate? We need to calculate dosage regimen, means how much amount of drug to be taken per day, means one time a day or two times a day, and how much dose to be taken by that particular adult male. Okay. Now few things are given, like aminophylline is a soluble salt of thiophyllene and contains 85% of thiophyllene. So S is equals to 0.85. Okay, S is the salt form of the drug. Okay, so aminophylline is there, and aminophylline contains thiophyllene. Thiophyllene is 100% bioavailable, so F is equals to 1. Okay, no doubt it is taken orally, but then also the bioavailability is 100%. Now we'll check out the first method. So we have got the equation d naught by tau equals to average steady state concentration into kVd divided by SF. But total body clearance, we have total body clearance, and total body clearance is also equals to kVd, that is elimination rate constant into the volume of distribution. So therefore d naught by tau is equals to C average into total body clearance divided by SF. Okay, so we are rearranging this thing. The dose rate is 34 mg per hour. To convert intravenous to oral therapy, the S, that is the salt form, and the bioavailability should be considered. Therefore oral thiophyllene is equals to oral thiophyllene, or you can say the average steady state concentration of the thiophyllene is equals to SF d naught by tau. Next we know the value of S, that is the salt form, which is 0.85. F is the bioavailability, that is 1. D naught by tau is the dosing rate, and that is 34 mg per hour. So we will get the value 28.9 mg per hour. So total daily dose is 29.9 into 24 hours, for which we get 693.6 mg per day, or approximately 700 mg per day. So dose of 350 mg every 12 hours could be given in sustained release form to avoid any excess high drug concentration in the body. So this is the first method. Now we'll check out the second method. So rate of intravenous infusion is 34 mg per hour, and so the daily dose is 34 mg per hour into 24 hours, for which we get 816 mg per day. So the equivalent dose in terms of thiophyllene, we should calculate in terms of thiophyllene. Okay, so we know aminophylline contains 85% of thiophyllene, so the salt form we get 0.85. So 816 into 0.85, we will get 693.6 mg, and this is also approximately 700 mg. Thus the patient should receive approximately 700 mg of thiophyllene per day, or 850 mg for every 12 hours. So this is how we can calculate the dosing regimen. Next we'll check out few of the pharmacodynamic consideration now. Okay, we have done with pharmacokinetics. Now we'll go for pharmacodynamics consideration. Okay, so the ideal oral medication should possess properties that results in minimal disruption of to the treatment course. Okay, the medication should have recognized activity towards the infection or condition being treated, and its use should be supported by clinical trials. To improve patient compliance, the medication should be available in dosage form that do not limit the patient's ability to tolerate the medications. Lastly, ingesting large tablets or capsules or having to take multiple doses per day is not desirable. Okay, so these all are pharmacodynamic consideration. So in all, at the end, what we can say about this pharmacodynamic consideration means whatever activity the intravenous therapy was producing, whatever kind of mechanism of action, whatever receptor it was interacting, and how much was its ability to kill the bacteria or to produce any of its activity, it should be almost similar with that of the oral therapy. Next, we'll check out some of the specific medication class consideration. Okay, so first of all, we'll check out for the fluoroquinolones. So ciprofloxacin, moxifloxacin and levofloxacin are included in almost all hospitals for intravenous to oral therapy conversion programs. These medications are ideal for conversion because of high bioavailability, rapid absorption and good distribution within the body. Remember that fluoroquinolones absorption may be affected by concurrent administration of products containing divalent and trivalent cations such as calcium, calcium containing antacids, iron and zinc salts, as well as medications like didanosine and sucralfate. For example, ciprofloxacin should be given 2 hours before or 6 hours after these products according to the manufacturer's packaging insert, obviously in order to avoid the interactions. Next, levofloxacin can be administered 2 hours before or 2 hours after these medications, and moxifloxacin should be administered 4 hours before and 8 hours after these medications. Ciprofloxacin suspension should not be administered via feeding tube due to its physical characteristics. Lastly, from dietary point of view, all quinolones can be taken without regards to meals. So these were regarding the some special consideration for fluoroquinolones. Next, we'll check out an important consideration regarding triazole antifungals. So the oral bioavailability of fluconazole, itraconazole, voriconazole and posaconazole is relatively good if administered appropriately. Fluconazole is well absorbed in most patients and is not affected by food or alteration in gastric pH. One study conducted in surgical patients with compromised gastrointestinal absorption receiving enteral nutrition reported fluconazole bioavailability to be 100%. Itraconazole is unique among triazoles in that it requires an acidic gastric pH for absorption. Okay, so antacids, H2 receptor antagonist and proton pump inhibitors can significantly reduce itraconazole bioavailability. Obviously, because these agents reduces the gastric acidity. So, in the product package insert, the manufacturer recommends administering the drug with a cola beverage if the patient is concurrently receiving an H2 receptor antagonist. Next, voriconazole is best absorbed if administered 1 hour prior to or 1 hour after meals. Both itraconazole and voriconazole intravenous formulations are contraindicated in renal dysfunctions because of the potential to accumulate cyclodextrin, which can lead to toxicity. Finally, posaconazole oral suspensions should be administered with high fat foods or tube feedings if possible, as this significantly increases the absorption. So this was regarding triazole antifungals. Next, we'll talk about vancomycin. This antibiotic is unique because it is one of the few medications where the oral and intravenous formulations have different uses. The intravenous formulation is used to treat gram-positive bacterial infections. However, the oral formulation is poorly absorbed and is typically only used in the treatment of Clostridium difficile. This medication should not be included in an intravenous to oral therapy conversion program. Obviously, like when any person is suffering from gram-positive infection, and obviously the doctor will prescribe vancomycin via intravenous route. Now, if he thinks that instead of intravenous, if I give it via oral route, obviously via oral route the medication will not kill gram-positive bacteria because of the poor absorption. And instead of that, it is more effective against the Clostridium difficile when given via the oral route. Okay, so intravenous route the action is different, and via the oral route a different action is produced by vancomycin. Next, regarding other antibiotics. Some antibiotics are better absorbed on an empty stomach, while others are better absorbed with food or high fat meal. Dietary restrictions may vary for other types of antibiotics. Linezolid. It is a unique because it is weak, non-selective, reversible inhibitors of monoamino oxidase. Patients receiving this drug should not consume food or beverages that are rich in tyramine because it can place them at a high risk for a serotonin syndrome type reaction, which leads to a severe hypertensive reaction. Although these foods are not commonly administered in hospital settings, it is still a concern, and many institutions will place patients on a low tyramine diet as a preventive measures. Lastly, we'll have a small summary regarding this entire topic. Intravenous to oral therapy conversion represents a cost-effective strategy that also minimizes intravenous therapy complications and facilitates earlier hospital discharge. Appropriate oral medication use produces equivalent clinical outcomes, causes fewer complications, less patient inconvenience, and is generally less costly. There are many medications that can be included in this program. So patients eligible for intravenous to oral therapy conversion, they should have a few properties, a few qualities, like they should able to tolerate the oral medication provided their gastrointestinal tract are perfectly working. Be converted to an oral agent that acts similar to the intravenous counterpart. Meet inclusive criteria. Obviously exclusive criteria we cannot compare, because exclusive criteria means here we need to give intravenous administration only. Next, not have any contraindication to the oral therapy and should be improving clinically. Though an intravenous to oral therapy conversion program, pharmacists have the opportunity to reduce unnecessary medication cost while maintaining the efficacy of the therapy and improving patient safety and comfort. So this is all regarding how to convert intravenous to oral therapy. I hope you people understood this video. Thank you for watching.